Never had that many computers. Me. So thanks for joining us, which on the, I believe, the last health research seminar series of the year. First and foremost, I'm sorry that I don't need a lot to be very confused. There you go. So first and foremost, I would like to first acknowledge that I am a humble and grateful guest on the Kiliklithenet territory, sorry, and that the Health Research Institute and the seminar series represents all the territory that are in the north of British Columbia. So I will just like to take a few moments to maybe, if you're online, acknowledge where you're from and just recognize the beautiful lands that we are sitting and working on, and soon enough, hear a panel. Okay, so here again, this is the committee of the Health Research Seminar Series. Me, Dr. Annie Duchesne, sorry, faculty in psychology, Kenda Ferber, faculty in the Northern Medical Program, Cameron, a graduate student in the Health Science Program, Bree and Liana, great support and help through this series. So again, throughout the seminar series, if you have questions, comments, ideas, we're always welcoming them, and you can reach any of us through emails. We're all very easy to find. Okay, we just wanted to highlight one event before we start our panel, which is actually a student winter gathering that will happen tomorrow, I believe. And this is basically everybody, every student who's welcome. I guess maybe some faculty, maybe, I don't know. But everybody's welcome, and it's just, again, to gather and discuss and start the holiday season in great fashion. Yes. Okay. Just to bring a bit more information to what's coming to you. So after the holiday and winter break, we will gather again on Tuesday, not Thursday, January 17 at the Bentley Center for a really great opening of the 2023 calendar. Again, this event is done in partnership with BC First Nation, and it's going to be about a case study reflection, remembering Kinyan, and the important call to action towards eliminating anti-Indigenous racism in health system. So please join us in January. We'll be sending you reminders to come at this event. Okay, so today we have an amazing panel, and this panel represents, I think, a very important dimension of the health research that we're doing at UNBC, but in Northern BC in general, which is an interdisciplinary research. And interdisciplinarity is something that I think a lot of people want to do. It provides a lot of amazing advantages. It makes every discipline grow when they can interact with other disciplines. But it's often also an art that there's guidelines, there's books, but it's really, there's a lot of art in it. How do you do interdisciplinary research? How do you do good interdisciplinary research? And I think that one really strong strength of the research at UNBC is this ability to do good interdisciplinary health research. And today we have an amazing example of this. So I think that the project that will be presented today is an example of great interdisciplinary research, but it's also an opportunity for you to ask questions about the project, but also the process of doing interdisciplinary research. And I would like to encourage you to ask questions about projects, but also the process. So the panelists that are here today are first Dr. Shannon Freeman, Associate Professor in the Faculty of Nursing, Mark Brew, Associate Professor in the School of Planning and Sustainability, Don Hemingway, an Adjunct Professor in Gender Studies, Social Work and Health Science, Keon Gourlay, did I say this name? I hope I perfect, Keon Gourlay, Research Assistant, and Emma Rosnaghian, Yale. Maybe I'm works. Okay. Apologies. Research manager at NBC. And without further ado, I'm just going to pass the baton to Shannon, who's going to introduce the team.
Fabulous. Thanks, Annie. And maybe I'll just start here by sharing my slides. So those of you who are online can see. And I will remember to click the share sound button this time. There we go. Alrighty. Can those of you who are anybody on their laptops confirm that you can see the slides okay? No, can't. Perfect. How about we try this? Oh, I can turn around and look at it. I can see them. There we go. So as Annie said, thanks for that great introduction, Annie. We appreciate it. I think if you're going to do interdisciplinary research, you should present as a team so you can get all of our different perspectives about what brought us together, what keeps us together, and what exciting fun things we were able to do together as a team. So we're going to focus on this project, which is what we call DemSCAPE, or the Dementia-inclusive Streets and Community Access, Participation, and Engagement Project, but we'll call it DemSCAPE. So just to start off with our introductions, maybe Dawn, you want to introduce yourself there first?
Sure. A little background. How did I end up doing research?
That's right.
Yes.
A bit about yourself and your journey, how it brought you here,
yeah,
and why are you interested in research?
Okay. So I grew up in an activist family. So the things that I can remember of my mother and my grandparents and my father was trying to sort out problems in our community. It was a very small community in British Columbia, Revelstoke, which is now a very big one, but at the time it was very teeny. So I kind of grew up in that atmosphere. And then in terms of the topic that we're talking about today, one of the first things that I did as a young student in what we had junior high school in those days was to work in a care facility. I worked in the kitchen after school from 3:30 to 7:30, unless we could finish faster, and then we got to leave and we still got paid for 4 hours. And in that experience, working in the kitchen, we would get the food prepared, push it out so that the staff would then take the trays into the rooms. And you may wonder why I'm telling you this, but as we pushed out the cart, we could see older adults in wheelchairs who were in restraints and whose chair was tied to the bar, the walking bar along the hallway. And we talked to each other, a couple of us that were in grade, I think we were in grade 8. And we thought, this is awful. And you could smell urine, and it was not a very pleasant experience. And so we made a decision that we would each adopt one of the residents, which to us meant we were going to spend time with them. So when we came out, we would go and talk to them. We would bring little gifts and just try and engage with them. And the thing that we found was that the two women that we engaged with seemed to be doing better than other people. And they started to respond to us and connect with us. And so I didn't know that was research, but that's really the beginning of my research. And it's something to really think about in your day-to-day life and what brings you here and the kinds of impacts that you can have. And there's many more, but we'll leave it there.
All right, thanks, Dawn. Mark, you want to introduce yourself next?
Sure. Hi, everyone. Dr. Mark Brew, as mentioned, associate professor in the School of Planning and Sustainability, also a registered professional planner. If I think about where my journey with research, which I understand to be lifelong interest in learning and inquiry, maybe started, the face that comes to mind is the face of my grandmother, Violet Brew. In about 3 weeks, my grandmother will celebrate her 90th birthday. She is also now in advanced stages of dementia, living back home in Atikokan. And over the last 10 years, as we've gone through that journey, I've watched, as we all have as a family, our relationship change and evolve into something new. But when I think about research, I can think a part of that relationship, which was me in the kitchen with my grandmother, cooking together. And cooking together with my grandmother meant having the hands and the dough together, doing something together. And when I think about interdisciplinary research and a chance to work with folks like we have here on the panel, that's what I think is really special about UNBC and interdisciplinary, it's not a chance just to come together and talk about the different things that we do, but to get our hands in the dough together and really learn along the way. So that's a little bit about me and where my journey starts.
Thanks, Mark. Kyung.
Yeah, I'm Keon. I'm an RA at UNBC. I've been working with Dr. Grew for quite a while. My research really started with him, looking at the history of Prince George last year. And then when this project came up, it was something really near and dear to me, as dementia does run in my family. And it's just been a really great opportunity to interact with other departments and really get a little bit more in my field and getting to know what's out there.
Thanks, Name. Anna.
Hi, I'm Emma. Where my journey started, I actually started out in microbiology. I worked in a wet lab at the National Microbiology Labs in Winnipeg. And I was working on human genetics and HIV, and I was doing PCR day in and day out. And it occurred to me at a certain point that I was more interested in the stories of the people, the cohort that our samples came from. And from that point, I really sought out positions and places where I could actually meet people and talk to them and hear their stories. Because I find a lot of love of talking to people I don't know and hearing their days, their lives, what brought them to that point. And so I moved over to public health, and I'm from a small prairie town. I moved to Vancouver, and I did a master's in public health, and kind of moved around in different areas and ended up here with Shannon.
Thanks. And I think that kind of circular path from where we came from to get here is very similar in my story as well. When I was very young, I'm originally from a very small town, about 800 people. And I was partially raised by my grandmother when I was in high school. And I always vowed that I would give back to her the kindness that she showed to me. So that's why I did my undergrad was in political science and in gerontology. So that I could learn my love of politics with my, interest in aging. And, many moons later, I graduated and I traveled all over the world, and then I went back to do a master's. And one of the things that's always fascinated me in my own personal story is why my grandmother, who seemed to do everything right from a very small town, died much younger than we would have wanted. And yet some people live to advanced ages. And so my first step in my master's research was looking at centenarians, right? And looking at functional profiles and caregivers of centenarians. And that's something that's my own personal curiosity. And then I've been involved in a lot of research following that. But I think the thing that unites us is that we are all very passionate about research and the value, and see the value that through research, we are able to make a difference. And there's lots of ways to make change in the world. And for us, one of those ways is research. And so I hope that through sharing our story and our journey about how we do this together from very different perspectives, from social work, from gerontology, from planning, that you get an idea that, when you work together, you can actually achieve some pretty awesome things. And so hopefully that will inspire you to think about, is there opportunity in your future for research to help make a difference? So talking about aging and making a difference, for those of you who are not in the gerontology field, immersed so much like Dawn and I, it's always important to talk about, our population is aging. We often say our population is graying. And we see these statistics a lot, where the aging population, things like that. So here's some statistics from CIHI that really highlight, that exponential increase that we're going to see. But when we look at this exponential increase and we really break it down across BC, it's not the same for everyone, right? We can say Canada's population is aging, but it's aging in many different ways. So our work that we talk about here is occurring in the Northern Health Authority. So that's this lovely teal box. And if you look at this is all the health authorities across BC. And you can see here, we look at the Vancouver Island and Island Health, about 24% of their population was 65 plus. And that's very different compared to Northern Health, where only about 13% of the population are age 65 plus. And I put this up for a few reasons. One is to show that there's a lot of diversity. And when people talk about the North and how the North is unique, we're also unique in how our population here is aging. But when we break that down a little bit further, these are actually Northern Health's numbers, right? And so while they may be the youngest health authority right now, they are going to see nearly tripling of their older adult population. And they really are looking at this orange line here, because this orange line is the population of people in the North, so living in Northern Health, who are age 75 plus, right? And so we're actually going to be seeing a decline in the proportion of the population 65 plus, but still continue to see that exponential increase in those who are 75 plus. And so it really brings to light the importance, looking at our demographic changes, about how the needs that we're seeing of older adults now and of our communities here in the North are going to increase and change and continue to do so over the next 2 decades. So we're going to talk today a lot about dementia, and I'll give you the numbers on dementia first, but I wanted to show a video here from the Alzheimer's Society in Wales, just to kind of set the stage about what we're talking about. So hopefully you can all hear this, and maybe Bree will monitor the online in case there's something wrong there. I think you've got to mute you're going to mute yourself there, and I'm going to unmute myself here. You tell me when you're ready. And I'm going to play.
I'm right tomorrow morning at 7 o'clock here on 107.9 FM.
Right. Right. What? I've forgotten. Should I?
Just go sit down. Just go sit down.
Yes. Right. Oh, that way. I don't watch. Oh, I don't know. Would you? Oh. I missed. I go. So I don't know. Oh dear. Chicken cheese. What? Chicken cheese? Sorry. Oh. Oh. People with dementia have experiences like this every day. A little bit of understanding, tolerance, and patience can make all the difference.
I'll tell you what, if you go into the seats just there,
Right.
when we get there, I'll call you, okay?
Okay, madam. I can't get on.
Let me help you this way.
Thank you.
Can I look at that list?
Yes.
Chicken and cheese.
Oh,
Let's go this way.
thank you. Find out how to become dementia friendly. Contact Alzheimer's Society.
So that's just a video to show you a bit about a
Glimpse. I'm gonna mute myself. So that we don't do what I just did. There we go. Okay. So I really like showing that video to kind of give you a bit of a perspective about, you know, what it's like to be living with dementia and in trying to navigate a daily environment which may have been familiar, but can become quite confusing and overwhelming as someone lives and experiences their journey with dementia. And this is important, I think, for everybody, regardless of what your focus is or what industry or where you're going to end up in life, that persons with dementia are living and aging in our community, and we can run into them anywhere, whether it's in research like the work we're doing, or it's being in the bank, or it's going to the grocery store, or it's finding somebody who's lost on the street. This is a study that just came out recently called the Landmark Study. And it's a very well-written study put out by the Alzheimer's Society that is all the Canadian numbers and the forecasts about what dementia is going to be in our community over the next few decades. And I want to draw your awareness to two things in these numbers. In the light blue, or in the dark blue here, you can see the exponential increase. And these are the numbers of persons in Canada who will be living with dementia. And the lighter blue lines here, and you can see they don't increase so much, are the number of people newly diagnosed with dementia. And there's two reasons that are really important to remember when we're thinking about the increase in the numbers and these are the prevalent cases of dementia. Two things. One, in Canada, we're doing better at diagnosing and earlier of diagnosing of persons living with dementia. And the second thing is we're doing better at supporting people to live longer with dementia in our country. So when we look at the incident cases, we don't see the same increase in the prevalent cases. But those numbers are not the same. So it's always important when you see those numbers. Yes, the prevalence of dementia is going to be increasing over the next couple of decades, but we will still continue to have a gender and sex difference in the prevalence of dementia, where we have quite a few more women who will be living with dementia compared to males. Another reason that it's important to think about what's the impact dementia is going to have on our communities is when we think about the persons who are supporting persons who are living with dementia. So we're thinking about caregivers, right? And the new term we more commonly use now is care partners. And a lot of times when we think about care partners and people supporting persons living with dementia, we're thinking of elderly spouses, right? But that's not really the accurate picture here. When we're looking at 2020, you can still see in our current numbers, care partners for persons with dementia are across all age groups. And we actually see the bulk of caregivers over time are going to be middle-aged. So usually those are either adult children, and also we see a lot more young onset dementia. So those are younger spouses of persons with dementia who likely may have small children or young families at home too. So our profiles of actually who is caregiving are changing over time as well. So the Landmark Study digs into a lot of things, and one of them is risk factors. And when we think about risk factors for dementia, there's lots of things that people can do, and those things differ across different ages. But one of the things that I think brings our team together, you know, is the importance of physical activity, healthy diet, with social connectedness. And in order to do a lot of those things, you need to be able to get out in your community, remain engaged in community. And so there's a lot that can be done to help reduce the risk factors for dementia, but also when people, even if someone already has dementia, some of these things can help them live longer and live better with dementia as well. So when we think about them, and I've already mentioned a few of them, I just thought I'd pull out to see. So in this report, they list 12. So if we think about what are things that you can do to reduce the risk of dementia, what kind of ideas and thoughts do you have? What do you think? And if you're on the, I'll put up the chat box. So if you're listening online, you can type in the chat box too, and I should be able, to see that.
Q&A. There's no chat box.
Oh, I put a chat box. Oh, okay. I've got Q&A. Okay, so type it in the Q&A section. But what do you guys think are things that can be done to reduce the risk for dementia?
Proper diet.
Okay.
Stop smoking.
Smoking, yeah.
Exercise.
Sleep.
Sleep.
Less alcohol. Access to green space.
Yeah.
Social engagement.
Yeah.
Mental engagement.
Yeah. And somebody just put in puzzles and different activities to keep the brain active. Reading, good one. Healthy food, socializing. Yeah. I see some people in this room who are very experienced caring for the elderly, but are quiet.
This is on the spot.
I can do that because that's my student. No guesses? Okay, well, you guys came up with 9. So let's see here, which ones were you missing? So physical activity, we got that one. Heart health, right? Protecting your heart. Social activities, we got that one. Managing medical conditions, right? Keeping on track of your overall health and wellness, yeah. Challenging your thinking, got that one. Sleep. Addressing depression is a big one, and depression has become much more prevalent during the COVID-19 pandemic across all age groups, so that's a big one. Alcohol, we got that. Hearing is a big one, right? Number 9. Number 10, finding meaning in life. That is a really good one. I did some research in my centenarian research areas about why they think that they have been able to live so long, and finding purpose and meaning in life was one of the secrets that came across all of the centenarians that were in that study that I did. Yeah. Avoiding head injury, and then a lot of you also talked about adopting healthy behaviors. So there's lots of things that we can do to reduce risk of dementia across all different age groups. Is everyone here from BC? Do we have people from not from BC? Right, good. So I'm originally from Ontario. Emma's from Manitoba, right? We think about the impact that dementia is going to have across Canada. I put this slide up there to say it's going to be different depending on the provinces where people are. So the landmark study here has really worked to model what's the increase in those numbers. And so you can see here in BC, we're expected to have more than a 200% increase. Whereas if we're looking into some of the East Coast provinces, that increase is predicted to be much less. So the number of cases, new cases of dementia that they're expecting is different across provinces. So when we just say our population is aging, as inquisitive people, you should always say, okay, but what does that mean, right? Because we're not all aging in the same way, in the same place. So when we think about the key issues that are facing someone to live with dementia and remain engaged and active in our community, you know, what do you think those might be? Maybe I'll start with our panelists first. If you were to think about what one issue that you think is really important facing persons living with dementia, what's your thought?
The social engagement piece, being involved in our community, is how do we be involved in our community?
Good, Mark?
Access and care and services.
I would say, I was going to say social engagement, but the piece about that that's really important is to be able to actually have that social engagement. So it means tying into how do you get somewhere? Is there something that you can get involved in, and how do you get there? So,
Jan, what do you think?
Lack of accessible infrastructure.
Yeah, accessible infrastructure. Good. What about the class? Any others to add to that list?
having meaning, going with what you mentioned there.
Mhm.
I mean, finding that you fit in and that somebody wants you to be there. And being part of something, belonging.
Yeah, and we tie that a lot into stigma, right?
Yeah.
And facing stigma and reducing stigma so that you can actually feel that. Yeah. Q&A in the box. Indifference. Maybe, I'm not sure I pronounced your name. Maybe you want to elaborate on what you mean by that a little bit more for us there. Well, I wait for you to take the answer. Any other ones, thoughts?
I was thinking accessing the diversity of healthcare practitioners, accessing them.
Good.
Adequate income.
Good one. Big one, yeah. Any other ones?
I might just share a little bit of history from this region that people may not be aware of, but in terms of talking about social engagement and really connecting with people, Prince George was actually one of the first places in British Columbia to have what was a peer support group for people who were at the early stages of dementia. And that was extremely important. And I had the privilege of being part of that process. It was part of my Master's of Science in Psych, actually, that work. And to see the just the warmth and the determination, that people had to be able to do this. And I don't know these days whether this would still happen, but one of the women volunteered her apartment and we actually met there, and until she wasn't able to host it anymore. But just to know, there's been some really families and people with dementia have come together in this community historically and done some really groundbreaking things that maybe aren't captured always fully in the literature or just in the news within the community. So something to remember.
Yeah, thanks, Dawn. And there's a couple others in the chat where someone had mentioned early detection and diagnosis and access to those opportunities to be diagnosed. Some that we pulled out at the background and the rationale for our work, and one of them is one of the biggest issues is this idea of a shrinking world, right? As you start to struggle with dementia, and then eventually, if you're able to become diagnosed with dementia, your world that you were once in can become much smaller, both physically in the fact of how you're getting out and doing things, but also socially in the people that you're interacting with and the way that you're interacting with. And we recognize the huge lack of supports, and Keon mentioned that, and the ability to be involved and get out and walk and actually do that in a way that promotes your independence rather than makes you rely on dependence of a care partner to take you out. So there's a lack of this idea that we'll talk about of supportive neighborhoods. And that's your social needs, your physical needs, your emotional needs as persons are living with it. And then also one of the challenges when we think about getting out and active in the environment is, where do you go?
Mm-hmm.
Where is there to go on a day like today when it's minus 25? Where would you go other than the mall? Where's actually the place to go? The only other place I would think of is to go walking at the CN Center. But having somewhere to actually go and be, what's the opportunities to get out there and do things, and so it's not just built environment, but also weather plays into that a lot as well. So when we think about issues that people with dementia are facing, some of them may be similar and some of them may be unique to their circumstances. Dawn, did you want to talk a little bit about this one?
About the human rights.
Mm-hmm.
Yeah, for sure. So I think one of the things that people sometimes assume that in terms of what the UN Convention is, that it's primarily focused on the question of physical disability. And it's not. It's focused on everything, and it includes the question of people who are having cognitive challenges. And so there is, based in that convention, we have a responsibility as a country, and I would say as a world, to actually address that question in a way that is as immediate and important as any other kind of accessibility issue. It is not just physical. And so for me, that is the biggest learning, but also sometimes the biggest hole in learning, that it's so important, I think, for all of us who are going to be involved in some way or other in doing some of this work, to really cotton on to that. And I would add, and this is my philosophy of life, that I, regardless of the UN declaration, I think all of us, by just dint of being human beings, have the right to have a good quality of life. And we have the resources in our world to be able to do that. We just have to be able to get together and make sure that those things happen. And it sometimes seems far afield, but I think the more we look at ourselves as a collective on this earth to be able to meet those needs, we can. And the challenge that I've seen, one of the challenges is the question of trying to decide, should more resources be put into younger people because they still have their whole life ahead of them. And then there's the older people, they've already had their life and maybe not quite so much. And we get put in this situation where we're debating, should more money go for, childcare, or should more money go for senior services, instead of looking at the collective and figuring out how to meet all those needs and not getting into a competition about them. So those are some of my thoughts.
Yeah, and I think it's important to recognize that dementia is recognized as a disability in the UN Convention on the Rights of Persons with a Disability. So it's actually recognized, it's actually part of that. And so when we start to think about that, realizing dementia is recognized as a disability, then a lot of these things become a lot more clear about how it's our duty to make sure everyone has equal access to things. And we talk about the social model of disability, cosmic barriers in the social and physical environment do not allow full participation of people with long-term physical, mental, intellectual, or sensory impairments. And so our work is really designed to actually address that. What can we do about that? How can we actually work together in an interdisciplinary environment to create tools and resources to actually support people to be more inclusive and to better understand when they're not being inclusive? So there's a very practical, pragmatic thing that runs behind the work that we're doing. But I think it's always important to put a face on the name of what we're actually talking about. And this is Roger Marple, and for those of you who know me, I do a lot in the Age-Well Network, and he was one of our persons with lived experience who is very vocal in our network, and a very strong advocate for persons living with dementia. And I really like this quote from him of what if we started with hope? The learning process for dementia needs to include hope for living well and practical ways to achieve this. And I think our team really embodies this quote on the fact of looking at practical ways to actually achieve this, and achieve this by learning from and learning with persons who are actually living with dementia and care partners who are caring for them. So Emma's going to show you some photos later about how we're actually doing this. And so we have lots of projects on our team, and this is a video. I'm going to show one more video here that I'm really proud to show. And some of you, even in this room, have also been part of this, and will recognize some of our BC people in this video that kind of hopes to give that face to that. So can you mute yourself? And I'm going to unmute myself, and we're going to try this again. So maybe we'll be 2 for 2. I'm unmuted. And there we go. So this video was what Emma helped with this one, and so did Chris, actually.
My name is Lloyd Schneider, and I'm here as a care partner. Many years ago, my partner, Karen, was diagnosed with Alzheimer's disease. I know it was difficult because of what was happening to Karen, but we shared things, and we did things cooperatively, and it turned out to be the best 5 years that we could have had given the situation.
My perception of this population has changed over time. I think it's something that a lot of people, including myself, are maybe a little worried or afraid of at the beginning because we think the worst. I think people have a lot of fear associated with cognitive impairment, and there's really no need for that.
I've got my wife and some grandkids, boy and a girl, and we have a daughter, and we all get along. So, I mean, it couldn't be any better, right? I play hockey in our driveway and all that good stuff with the young guy. And even grandma comes sometimes. Oh, yeah, it's a riot.
A lot of the times we think because they don't have a good memory or they're unable to remember things or communicate effectively, that also means they're physically unable to do something. And I'd say that's most often not true.
My husband, Bill, he's just an amazing person. He's so kind with everybody. Bill and I always go walking every day. Even when I come here for exercise, we've already done our walk in the morning. And I think it clears your mind and makes you think better, you know?
I was diagnosed with dementia about 5 years ago, and I've been living quite well with it ever since. When we moved to our apartment, I started doing Tai Chi right across the street. I'm very lucky in this group, they let me be in the middle. So wherever I am, I have somebody to see. And if I don't remember what the move is, I can figure it out pretty quickly.
When we think about our participants, we're only seeing them as who they are in that moment. They may have a view of what they were able to do even a year, 5 years ago, and now they feel they're not able to do that. And we're going to meet them where they are.
They're not alone. We have people from all walks, all spectrums, all, everything, and they fit.
So I think living well is being as comfortable and as happy as you can be with the situation you have. And it's, where are you right now? What makes you happy now? And if that means having the same question 5 times in a row, that's where Dad is. And I will meet him there and ensure that his dignity is there.
Well, I mean, golf it's the one that sort of queued me up here. I'm a baseball and hockey guy, but now here I am, going out here with the golf clubs and stuff.
A lot of my participants are coming up to me constantly asking for tips. Like, I want to be a better driver of the golf ball, or I want to make more putts. So I think that's what has inspired me the most, is to see them achieving their goals and continue to setting goals and wanting to get better.
When Karen was diagnosed, she wanted to train to run a marathon. She worked hard at it, and she was able to get up to running a half marathon before she had to withdraw from training. One of the memories I have was at the end of a training race where this gentleman walked up to her and said, "Thank you so much for keeping me going. You kept me going." So I run to this day because of that.
All of us have our strengths and our weaknesses, and people with cognitive impairment are just the same. They have strengths and they have weaknesses too. So I think we focus on their strengths and their abilities first, rather than on the limitations.
So I'll stop that and I'm gonna mute myself. Are you good? We're good. So those were some videos that were produced, and I hope you didn't recognize some people you might know in there. My kids were the ones walking the dog with my neighbor Wilma, who often comes to help us out in our research. Chris's wife and family were in there as well. But always remember, in all of the work that we do, is to keep the person and the people that the work is focused on at the heart of what we do. And so we are an interdisciplinary team to support them. So that's what we want to emphasize there. And so a big theme in the work that we'll talk about here is accessibility and inclusion. And we hear that from older adults and care partners. We hear that from our own work and our own perspectives, lived experience. We can tie it all the way up to the WHO. So that looking at how can we enhance accessibility and inclusion of persons living with dementia in our communities is really what sparked us to come together for this research project. So today we're going to give you, this is an example of one of the many things that we're doing, talking about our DemSCAPE project. So we lead the Northern BC wing of this project. It's led by SFU, and there's a lot of work being done in the Lower Mainland on this, but Mark and Dawn and I and Keon and Emma really comprise the UNBC team, along with quite a few different research assistants who supported us. We have quite an array. Our international MyTax students were part of this work. We have lots of RAs on our team who have come to help out as well. So while the 5 of us present to you today, please know that this is work that's done by a much larger team. So shall I pass it over to you?
Yeah, I'll tackle the rationale here. And I'm going to try and do that by inviting you guys, if you might, to give you a little bit of trust and join me in closing your eyes for just a moment. And now that I'm no longer nervous because you're not looking at me anymore, I'm going to ask you to imagine walking out your front door. I'm going to ask you to picture what's outside your front door in the outdoor environment. Just take a little bit of a look around. What you're looking at in your mind's eye is your neighborhood. It is the first environment we experience when we leave our home. And I want you to think about what the feeling is evoked when you think about making a trip through that neighborhood by some sort of a mode of transportation that is not our car. Maybe that's walking. Maybe that's walking with an assistive device. Maybe that's wheeling through your neighborhood. Right? Perhaps the feelings that you experience are those of comfort, excitement, enjoyment. Right? Perhaps they're feelings of uncertainty, anxiety, fear. We actually know quite a lot about the different barriers and enablers of the experiences of our neighborhoods from a planning and design perspective. But one of the things we've done in our professions of planning and design is often commit the sin of assuming that there's a single general public out there. So what we know, or what we think we know, right, is about this mythical general public and their needs. The rationale for the DemSCAPE project, I think, really stems from the fact that when we start to chip away at that myth of a general public and start to think about the different communities and the very diverse needs that those communities have, as Shannon's been talking about, we see there's actually, despite some growing studies, a relatively significant evidence gap in trying to understand not the enablers and barriers of engaging in your neighborhood from a general perspective, but evidence evidence that tells us something about a particular population, in this case, those who might be living with dementia. And so the rationale for the DemSCAPE project really, I think, is trying to peel away some of the layers of that onion that we've been assuming in terms of what we know about our neighborhood, and really trying to go deeper to understanding for different communities how those different enablers and barriers might actually be experienced, what they are. Yes, or you guys can go for that. Thank you. All that trust.
It's a dangerous thing, Mark.
Sure, okay. So, as I said, my name's Emma, and I'm kind of in charge of the day-to-day activities of DemSCAPE. And we have 4 main objectives you'll see here. So the first one, identifying neighborhood destinations that persons living with dementia visit and changes in the patterns of visits over time. That was kind of the main one. And we'll talk maybe a little bit more about it later, but we're starting to realize that the destinations that might have been identified in the southern part of the province really is not reflected in our northern neighborhoods. Then identify neighborhood built environment features that affect mobility, engagement, and social participation. This is something that Mark was talking about, as well as the rest of the panel. This is a little bit more down the line, but develop an easy to use environmental audit and advocacy tool. And that is really to evaluate the dementia friendliness of neighborhoods, and then develop planning and design guidelines to inform decision makers, such as municipal policymakers, city planners, and the like. Really with the ultimate goal of creating more dementia-inclusive neighborhoods, which really means inclusive not only for persons living with dementia, but their care partners, their families, all of us. And so these are our methods. It's a little bit of a timeline here we had. So we actually had 4 different data collection activities. We had our first session where we had our first sit-down interview. During that time, we got demographics. We talked about their out of their house activities that they did in their neighborhoods. And we talked about their walking routines, as well as we did a survey called the ACTO survey. Then in session 2, we did a semi-structured sit-down interview, and we also did the route planning. So we asked them where they walked in their neighborhood, where they usually go, what are their normal daily routines with that. And then we collaborated with either the participant or the dyad, which would be the person living with dementia or the care partner, to figure out which were the best routes that we could potentially do. Then in between session 2 and 3, actually, myself and usually Keone would go and do a safety walk. So we would go through and look at the routes that were identified, just to make sure everything was safe. And as we kind of talked about with the changing weather, that changed quite often. And so that was an interesting events that might happen due to that, which we might talk about a little bit later in the realities of research. And so then we would do the walk along. And this is when we would go to the participant's house, and we would start at their house and do a walk in their neighborhood. We would talk about how the participants perceived their neighborhood, what they liked about their neighborhood, things that they noticed that changed, guide points, really just a conversation while we walked about the neighborhood and what they were experiencing. And then we had one more session where we would do a sit-down interview, and we would show video from the walk along as well as photos, so that we could hopefully delve a little bit deeper into some of the pieces and features within the neighborhood and their experience with those. And so that was kind of the 1 to 4 there. The geographic location we've mentioned, the goal is 24 to 30 community dwelling persons living with dementia and their care partners if they so chose to participate in both Metro Vancouver and in Prince George. And so we kind of talked about this in a little bit more detail. We used a mixed methods approach. We did that act out survey, walk along interview, photographic and videographic documentation, as well as the face-to-face sit-down interviews. The act out survey itself stands for participation in activities and places outside the home for adults. It was a validated tool designed to collect quantitative data on participation in place-based activities outside of the home and for those living with dementia in our communities. There were 3 different dimensions, I believe, where we would ask them if they had gone to certain clusters of places. So for instance, we would talk about administrative buildings. So did you go to the police station? Did you go to City Hall? And then we would ask if they used to go there and if they see themselves going there in the future. So there was a temporal portion to this survey where we could look at the patterns of their activities outside of the home. And the walk along interviews. So it was a guided conversation that I would have with the participant or the dyad about the neighborhood environmental area, talking about their perception, mobility, how they moved through their neighborhood, the behaviors of walking through their neighborhood. And this mainly did take place in the participants' neighborhood, although in northern BC, as well as specifically Prince George, a lot of people do walk for exercise, which means that it wasn't always in their neighborhood. They might go to a park because it was the safest place to go, things like that. And it was usually about 60 to 90 minutes, give or take. So talking about the photo and video documentation, it was a whole production actually to do the walk along. We had Keown wearing a camera on her head, which you will see soon enough. We had RAs following behind us. Yes, I did have that photo. We had either the participant wear the GoPro or I would hold the GoPro. There was the need to be very flexible in this. And we would stop and talk about different environmental features that were identified by the participant or the care partner. And we would take photographs, we'd make sure we had video of it. And then those were what were used in the final sit-down interview. So the face-to-face interviews that I talked about in session 1, 2, and 4, we would have them with each participant and their care partner in their homes. Really, it was talking mostly about their experiences in their neighborhood, experiences with walking, experiences with their diagnosis as well as walking, and then those particular aspects of the neighborhood that were harder or easier for them and facilitated that meaningful connection or didn't. So now we have some photos of the walk along prep. As you can see that photo of Keown, beautiful Keown. She would be walking behind us with that GoPro. The baseball hat didn't work that well, so we had to change to a different mounted headpiece. That is myself making sure the camera was on. It was not. That was our pilot run. It did not record a darn thing. And then you can see our pilot walk here down in the corner, where Keown is not recording the walk. And we have our MyTax students in the back there and RA that worked with us. And they were walking behind me and the participants touching all of the really important pieces of the walk along. And so now you can see the actual walk along. It's mostly me walking beside the participant and Keown. These were all lovely photos and video from Keown. So you can see we did it in a variety of seasons. Very nice summer up there, very horrible winter icy conditions, but the participants persevered. I kept being like, turn around, and they were like, nope, we're gonna keep going. So we all managed not to fall, and that was a really big victory. And then we have down in the corner there, you'll see most of the participants actually used mobility aids, and that was a really big part of our findings, seeing the built environment and how mobility aids do always help. And then we have a nice picture walking down the back lane there with a participant, and that was because there was no sidewalks on the road, so they chose to walk down back lanes. So kind of things like that. And then we have some features of the neighborhood built environment that we might call barriers. So you can see in that first picture there, having to push a wheelchair down that path was very, very difficult. Lots of cracks, lots of issues there. The next picture shows, like many roads in Fiji, no sidewalk whatsoever. Then we have some routes there across some of the paths that our participants took. Also, again, not very suitable for people with a mobility aid. And then this last picture here, you can kind of see the tip of the participant's feet. She was using a walker, and trying to get off that ledge was very, very difficult. So these are some of the things, some of the examples of the barriers that we found in our Prince George communities, neighborhoods. And then we also, these are features, so we would talk with the participants about how they navigated their walk. things that they would find familiar or that they always stop to look at. And you can see in this first one, might not be super clear, but there's a huge notch in that tree. And this was one of our first walks, and the participant was quite quiet, and all of a sudden notch yells at it. And so we were able to take photos, and he talked a lot about how the notch in that tree, a branch had fallen off. And it was a big change for him in that walk, but he always knew to turn when that tree came up. And so that was a nice little story. Another participant really talked about flowers a lot, loved all the flowers on the routes she took. The other one here was another change with construction. That was a new thing for that participant to see that. It was something to point out. And then this last photo here, the patch on the hydrant, that was also made the participant laugh. She loved that. And that was a nice little feature of things that change in your neighborhood and how persons living with dementia might navigate and see that, oh, I turn right here, there's that hat. So those are some of the interesting things we found. And so now we're going to dig a bit deeper into the realities of actually doing research, and I'm going to turn it over to Mark.
Yeah, one of the things we are piloting here in the northern arm of the DemSCAPE study, I'll say we liberally, and then give a lot of credit to Gil for exceptional work on this, is something referred to as a watershed analysis. And if we jump to the next slide, what we have been doing is trying to pair a lot of this great qualitative information that we've been able to garner working with participants about their overall neighborhood, and pair this with what has been a long-standing technique in the field of planning and design in terms of doing a watershed analysis. So we have all this great information that participants are telling us about barriers and enablers along walking routes in their neighborhoods, as Emma was demonstrating. What we've been trying to do with the watershed analysis is paint a bit of a broader context of the attachment that is available to each participant in their neighborhood. So what a watershed really is, I would argue, is two different things. In a very functionalist perspective, it is the area that is available to you from any one point, for instance, your home as you visualized it, that area being available to you at a distance or over a time where walking is competitive as a mode of mobility to driving a car. And what most evidence suggests is that we will walk about 800 meters or about 5 to 10 minutes before we say, nah, I think I'm going to jump in my car and drive to get that quarter mile. So the watershed can be analyzed either as an as the crow flies area from a central point. We used a little bit more of an advanced technique that actually measures how far can you move along the pedestrian network. Sometimes pedestrian network in Prince George just means the streets, unfortunately, within about a 400, 800, and 100 meter distance. That's what's available to us if we are choosing to use walking as a mode to get out into our neighborhood to complete some sort of a task. The other thing that watershed really is, I think, a way of thinking about planning and design and how we work with data and analyze data. Right? Probably many of us have heard the saying, what we measure is what we do. One of the things we have not done for a long period of time in the planning and design field is spend enough time measuring things at the scale of the pedestrian. So what watershed analysis really tries to do is shift our analyses and our focus to the scale where walking is a primary or competitive mode of mobility, right? With the hopes that with that evidence, we can be better prepared to inform planning and design and policy that actually puts in place more enablers and gets out of the way a lot of the barriers that I'm talking. So as was mentioned by Shannon, access and inclusion is a pretty major foundation for the DemSCAPE project and a lot of the work that we do together. In addition to the convention that Dawn talked about, in Canada and in the province of British Columbia, we now have two pieces of legislation that we should have regard for. We now have accessibility legislation at a national level. We also have accessibility legislation at a provincial level. And the legislation, amongst other things, starts to define and lay out what it is we ought to be thinking about in terms of addressing some of these barriers. And if you dig in, what we find is that barriers are generally related to the notion of an individual's ability to be self-determining in their participation in some sort of an environment. Right? In this case, we're particularly interested in the neighborhood environment. But what I really, really loved hearing from the crowd was that at the heart of all this is this notion of belonging. But that's why that participation in piece of this connection is so important. That access and inclusion happens when planning, management, design, where we're directing our attention and our resources, right, is enabling participation and creating a sense of belonging. One of the things I think about a lot from the planning and design profession is this relationship that we have built into our team, referred to by Iverson and Stahl as person-environment fit. Right, so we see here a graph showing how our functional capacity might change over our life course. And in the red line, we would represent what Iverson and Stahl call environmental press, the demands that the environment puts on us, given any sort of capacity we're bringing to that situation, which will evolve over our life course. Right, so we can see, if we think about the social model of disability, where we might dip below that red line, right, we are being socially put into the experience of disability. Planners and designers, by the nature of our profession, tend not to work on a case-by-case or individual basis with folks. But what we do is spend a lot of time upstream shaping particularly the built environments that people navigate and use. So we are the source of and potentially the solution to a lot of the environmental press or demand that is putting people into the experience of disability. So while we might not be able to work with individuals on a case-by-case basis, if we could flip to the next slide, what we can do is change the way we do planning and design and lower that amount of environmental press and change the experience for a whole range of our community so that they're no longer experiencing this social construction of disability that we're causing for our planning and design decisions. I'll turn it over now to Fiona to talk a little bit about what we've been doing from an empirical research standpoint in our watershed analyses.
Okay, great. So we created a watershed framework here. It's based on a criteria and indicator approach. This was used as it standardizes results across all the different watersheds that we're being analyzing. And it gives specific and observable analysis as well as indicators that are actually measurable. This list of criteria here is just a very short list. I think we had something like 120 different unique criteria, and they're all compiled from literature review based on people living with dementia and their interactions with their environment. And in general, these criteria affect people living with dementia in three ways, which are change of route preference or avoidance of a route, creating a more enjoyable experience, or aiding in wayfinding. Some of these examples here are having sidewalks, which can lead to changing routes, as I mentioned before. Street trees, which can provide an enjoyable experience, especially on a hot summer day where they provide comfort from shade. And landmarks or saliency, with saliency being the ability to differentiate between one building and the next, which aid in wayfinding. And of course, these criteria are going to overlap in the way that they help people. For example, a tree can also be a landmark, as we saw with one of our participants. These criteria are also sorted into dimensions. As we can see here, the accessibility dimension includes the criteria snow plowing, stairs, and wheelchair accessibility. At level 2, that's when we introduce the indicators, as you can see on the chart here. These indicators are assigned to criteria, some of them based on the literature, and other of them were based just on intuition. For example, something like population density, you just know what people per kilometer squared. And others, such as like public open space, are based on similar criteria. So something like green space, which does have measurable indicators in the literature review, was measured in a similar or the open space was measured in a similar way to green space. At level 3, this is when we make a new table that is based on what we can actually measure in a GIS setting or with census data. For example, graffiti is something that does come up several times in the literature as being a poor environmental quality factor, but it's not something that we can measure in a lab setting, as the GIS information includes built or intentional infrastructure. This framework was then applied to watersheds based on the participants' residence. So this is our first participant's watershed, who we've named Ruth in this situation. And as you can see here, we've based this watershed on their residence, although this is the one instance where they didn't actually walk in their watershed at all, because it was so poor. We went to the HRI Park instead, which was lovely, but we still wanted to create this watershed to see why they didn't want to walk in it. This is just meant to be an example of how to categorize their experience in their neighborhood. This watershed was comprised, as Mark had mentioned, we used the walking network, which uses trail systems, sidewalks, streets, and pathways. And we did the analysis at the 400, which is the lightest color in the middle, 800, which is the yellow, and then the 1,000 meter, which is the brown on the outside. So those are the distances from the residents. Although the analysis was all done at the 1,000 meter or the 1 kilometer distance, because we don't want to assume that just because a person living with dementia has dementia means that they're not able to walk a full distance. So when we're looking at this, you can see the full list of criteria that we were able to measure. A lot of these things are not present in the watershed, but most of note that made this area actually very difficult for someone with dementia to navigate is the actual layout of the streets themselves, which is called the curvilinear block pattern, or loops and lollipops pattern, which is the repetition of cul-de-sacs and crescent streets. This can be very confusing for someone living with dementia. You go in one area, you come out the same place, but you may think you're in a different place and you can't tell one street from the next. Additionally, you can see here only 31% of streets actually have sidewalks. And so that's 31% of streets have sidewalks on one or both sides, as compiled by the amount of streets. And there's actually only one bench in this entire 1,000 meter watershed, despite the presence of green spaces. And the first participant, who we're calling Ruth, did use a mobility aid, and because of the lack of sidewalks and the lack of rest places, this was just not an option for them to be able to walk in.
So where I thought I would land with some of this watershed stuff, thinking again about the realities of research, is around some pretty significant announcements at a provincial scale for those who might be paying attention to planning or housing related policy. One of the realities of research is we are always embedded in an evolving policy and political context. So some of you may know that our new premier has made major announcements related to the housing crisis that we are experiencing. Along with that has come some conversation about working with municipalities to set and hit housing targets, and where necessary, to impose targets on municipality should we get to that point. This is a very significant pivot towards centralized planning in the province of British Columbia. This has been happening in Ontario since around 2006, with some of the implementation of a Places to Grow framework that saw the province take a very strong and firm hand around setting targets for development in cities around the Greater Toronto Area, but relatively new in the province of British Columbia, where we have had a far more decentralized approach to planning. It's still very early days. This announcement was only in the last week or two, but some of the critiques that are starting to come out are asking, well, if we're going to deliver targets around housing, what are we tying those targets to? Are we tying them to targets around performance for climate change? Are we tying them to targets around thinking about how we can redesign neighborhoods to be more accessible and more inclusive? Right? The answer at the present moment appears to be no. So the question I have is whether or not, as we start to pull on this really significant lever, right, if we're leaving a whole bunch of potential co-benefits on the table. by not thinking about how we can actually tie in a broader set of policies.
So those are some of the realities of research. And I just, I wanted to ask, Keon and Emma, if you could share with us, some things that have surprised you through the process of being out there on the streets. Excuse me.
I think one thing that is really surprising, that just the perseverance, even when a neighborhood like the first participant is not at all walkable, they still are trying to go out and improve their own quality of life. This participant, they walk at Lately Canadian Park. They also walk in the mall during the winter time, go to CM Center. Like, they're just so ready to look for other opportunities because people have not provided them with the opportunities.
Something that has surprised me. Well, I was actually going to say the same thing as Gail. But also, I think when you're approaching qualitative research and research where you're talking face to face with people, you need to approach it with kind of a sense of wonder and receptiveness. And so I would like to say that all of the answers or all of the thoughts that participants share with me is a surprise. I want to go in with really kind of a clean slate in my head and to hear what they have to say. There's always one thing that they say that I'm like, oh, I didn't even think of that. And it's really wonderful when you do get to hear those things. One specific thing actually was that one of our participants talked about the social aspect of walking, but not that they would speak with people. It was just waving. Every day they could wave at someone, and being somewhat isolated, I think that was a really big, meaningful interaction for that participant, and it was really wonderful to hear that from them.
Is there anything that either of you had expected that you didn't see, or that didn't occur, that you thought would be something that you thought it would be, but it wasn't?
Well, one thing that actually Emma pointed out was the participant trying to get her walker up onto where there was no drop curb. Like, we noticed these things. She did not. She just kept going, and she was going so fast. I had to like sprint to keep up with her. Yeah, it's like just I expected her to be wary or cautious. And no, she walked the same route every day. She knows what she's doing. Mm-hmm. She just went, and it's nice to see.
That's really that's really quite true. I think another piece. I didn't grow up here. And just like the lack of sidewalk really surprised me. Just no sidewalks. But then again, participants walking down the middle of the road, like this is their sidewalk, it's this big now, rather than on the side. And just some of the issues that they do run into, but also that resilience to just adapt and deal with it and continue on. So that was definitely interesting.
So what was it like for you to actually be working with persons who are living with dementia and their caregivers and going into their homes and learning about them and their stories and their environment? What was that like? What was that like for you?
It's definitely humbling just to see like all the support that all our participants have had a care partner with them, and just to see the support and in some cases just the acceptance from both the partner and the person living with dementia themselves. It's just you're really grateful. You always thank them, and they're always so happy to help as well. So it's just a really cool experience. It's been really enjoyable.
Yeah, I think it's actually quite wonderful to do research with persons living with dementia and their care partners. Having the opportunity to listen and chat about that participant's life, their daily experiences, really is a privilege. And I mean, when I sit down and think about how often do we get to sit down and just talk about ourselves or our opinions or how we see the world. And I think that being able to facilitate that opportunity as well as be a part of that is really, really meaningful. And getting to hear those stories that always end up, you know, we might be talking about a street, but then all of a sudden we're talking about where they grew up and how they experienced things when they were younger. And it's really, really nice to hear those stories and get to share in those memories with those participants.
And I think that really echoes something that we do a lot in research when we're working with people with lived experiences, to meet them where they are at that time on that day. And sometimes people are having a great day and sometimes they're not, and having to have that flexibility to be responsive to support them and really level that playing field. So whatever we can do as researchers to help be inclusive, to shift what we're doing so that they have the ability to participate in the research. And I think when you are able to do that and you are able to authentically listen to them in a supportive environment, that's where you can really get at, you know, the heart of what is happening. And, you know, we do research to make a difference. We do research to make an impact. And so I wanted to ask you, Dawn, if you would share a bit, you know, I always admire you from the minute I came to UNBC and I met you. And I've always looked up to you for your role as a researcher, as an advocate, you know, and research is not just that next journal publication. Research to make an impact also is about research for advocacy. So can you share a little bit about that in your career, and, you know, any suggestions you have for our audience today, whether in person or online?
Maybe I'll start just by saying briefly that, you know, there's some of the assumptions when you're working with older adults and thinking particularly about those experiencing dementia, assumptions about incapacity, and rather than looking at capacity. And I think this question, if you're going to work in this area, is extremely important because people have capacity and people have the right to be able to be their own spokesperson. And we've had in British Columbia some legislation that sometimes we don't know about. Certainly in social work, it's one of the pieces that's important. And that is, it's called the adult guardianship legislation. And you guys might want to look it up at some point and just see that it looks at the question of capacity, not whether you can say, you know, tell a tale about something, but whether you can express through whatever means, it doesn't have to be verbal, what you're feeling about something. And so we look at really not looking at the things that aren't there if someone is experiencing dementia, but the things that are there, and that they become part of that mobilization to try and bring about change. And I think one of the things, I'm not sure how much time we have, but one of the things that
2 minutes.
2 minutes, holy smokes. Okay, can't do that. Let me just say that if you're going to do research in any area, you should look at what's going on around you in the community. So let me give you an example for around the question of seniors and older adults in our community. We have a big council of advisors to the Council of Seniors in Prince George. It has everybody on it that is providing services to older adults. Shannon and I sit on that. Really important to listen to what's going on in the senior centers, what's going on at the Y. Where are older adults? What are the kinds of things? What's happening in the sports things that they're involved in, or the development of the exercise equipment down at near the Y that's there. Yeah, all those things. And also looking at where you can get engaged as a researcher, as a student, as someone in that area. So for example, we have in BC, we have a seniors advocate, which is something that's relatively new. Some of us fought for that some years ago, and we now have that. And we have an advisory body to her. And in Northern BC and Northern Health, we've got 3 people. One of you guys might end up being that one day. I get to be that right now because I'm already a senior. But there's 3 of us in the Northern Health region that give input to Isabel McKenzie about the things she's doing. And you should look up some of that stuff. We're not going to have time to talk about it, but you should look up some of the reports she's been doing recently. Really important work. And I would just really encourage you, doing research, being a student, being out there and whatever work you're going to do, look to the community and see what's going on there, engage people, do things with people, not about people. And I could talk about this.
And I love that, you know, that summary statement about doing things with people, right?
Yeah.
If we do things with them and we partner with them and we're all equal voices at the table,
yeah, then
we can actually achieve things that are meaningful to them if we listen to what that may be. We talk a lot about research impact, and so for those of you who need a book, can't be an academic without telling you a book to read. I will leave you with this one. This is a book that some of us at UNBC contributed to. You'll notice some of your profs' names in there. And it's a book that's written for trainees. It's written for upper year undergrad students, for grad students, and for emerging scholars and trainees about how to take your idea and actually take it from knowledge to research to impact. And it's a very practical book in there. So I have some copies in my lab, but I'm sure you can also download the chapters for free online. But they're really useful, practical ways. So if you're trying to learn, you know, the how, you know, then you can have some good resources there. So with that, I want to say thank you to Keon and to Emma and to Dawn and to Mark for joining today on this panel. We hope we inspired you. And I'll pass it back to Annie there.
Yeah, and it was quite a bit tour de force to just basically, I think tour de force with an accent, but I mean, it was just really compelling to see the different perspective that you get. And I think that there's one really important key is the notion that to combine disciplines, but it's also, again, the notion of doing with and always keeping this perspective, either from one discipline to another, but definitely when you're doing health research, the people you're doing research with and for, and keeping that at the center and finding ways to doing that by also combining disciplines. I found that this was very well actually explained. We are really short on time, but I was just wondering if there was questions maybe from the audience or questions from the chat. Don't know if you have questions, comments. It was really, I feel it was great because there was so much to take in. I feel like I want to, every time I'm listening to an amazing panel, like I just want to go back and be a student. What if, you know, and I think thanks for also recommending the book. And I would encourage if there's training, really like whenever somebody's recommending a book, just jump on this. This is a great opportunity.
Can I say one last thing? So just remember, you can make a difference, okay? So when I started here, if you looked at what the research ethics, what the Tri-Council document looked like, and you look at it now in terms of how it deals with some of these questions, you wouldn't believe it. And so, well, you might. And some of us, you might actually. But I think it's really, really important because, and also you sometimes got to push a little back at our research ethics board too, just a touch. Because just to say, wait a minute, you know, I mean, I remember doing research with someone with around mental health issues, and we were told that we had to make sure we had to have someone come in and make sure they weren't in psychosis or something. And so we made some arguments that said, you know, does that mean that someone who's out there researching trees has to make sure the guy that they're talking to out there isn't in psychosis? Because these are people living in the community. They're just fine, thank you very much. And so we ended up with someone from the Canadian Mental Health Association on the REB. So I'm just saying, you have, you know, you can do a little push. So just
and it's nice on that point in BC. We have some very strong voices of persons who are living with dementia, who are really going after our ethics boards so that our ethics boards can better understand living with dementia, so they can better understand how to reduce some of that unconscious bias towards persons with dementia. And so I'm optimistic that we'll see some enhancement for better inclusion of persons with dementia in research in the future. But always areas for improvement and progress to move forward. But yeah,
and we can see we have. So that's I mean, that's what I want to share with you. We can make a difference.
Well, I mean, I have lots of questions, but I'm going to keep them and ask them to you afterwards. Thank you very much. Thank you for, again, this amazing project, and it's very inspiring. So I think it's a nice way to end the year. and to think about new research coming into the new year. Thank you very much.